Hi everyone, my name is Swati and I'm a third-year medical student at UBC. I made this video with Dr. Janine Roller, a plastic surgeon working in British Columbia. Today we will be discussing an approach to the cranial nerve exam. We will begin by going over the cranial nerves and their functions. We will then discuss the cranial nerve exam. There are 12 cranial nerves that stem from various parts of the brain. Each nerve either carries sensory, motor, or both modalities. The 12 cranial nerves are the olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal nerves. Some nerves carry special sensory information. These include cranial nerve 1, 2, 8, and 7 and 10 for smell, vision, hearing, and taste respectively. The olfactory nerve is a sensory nerve that transmits information about smell. The nerve starts at the olfactory mucosa in the roof of your nostril and extends through the cribriform plate of the ethmoid bone into two olfactory bulbs, one for each nostril, sending information along the olfactory tract into the brain. The optic nerve functions as a sensory nerve that transmits information about sight. The nerve starts at the retinal ganglion cells in your eyes and extends to the optic chiasm. At the optic chiasm, nerve fibers from the medial half of the retina cross over to the opposite side of the brain. The fibers from the lateral half of the retina travel to the ipsilateral side of the brain. These fibers then travel to the thalamus and are projected to various lobes of the brain, like the parietal, temporal, and occipital lobes. The oculomotor nerve functions as a motor nerve for extraocular eye movements. The nerve goes through the superior orbital fissure into the orbit. The oculomotor nerve innervates the extraocular muscles of the eye, including the inferior, superior medial rectus, inferior oblique, and levator palpebrae superioris muscle of the eye. The superior rectus works to elevate the eye, while the inferior rectus depresses the eye. The medial rectus adducts the eye. The inferior oblique causes upward and outward movement, while the levator palpebrae elevates and retracts the upper eyelid. The trochlear nerve functions as a motor nerve that innervates the superior oblique, causing inward and downward movement of the eye. The trigeminal nerve carries both motor and sensory fibers for the muscles of mastication and sensation of the face, respectively. This nerve has three divisions: ophthalmic, maxillary, and mandibular. The ophthalmic division provides sensation from the crown of the head to the upper eyelid while also providing parasympathetic function to the lacrimal gland. The maxillary division supplies sensory innervation from the lower eyelid to the upper lip. It also provides parasympathetic innervation to the gingiva and mucosa in the mouth near the hard palate. The mandibular division carries both sensory and motor fibers. It provides sensation from the lower lip to the lower border of the mandible and provides motor to the muscles of mastication. These muscles include the masseter muscle, lateral pterygoid, temporalis, and several other muscles. When completing a cranial nerve exam, sensation is recorded as VIII, VIII, or VIII. The abducens nerve functions as a motor nerve that starts at the abducens nucleus in the caudal pons. It innervates the lateral rectus muscle, which abducts or abducts the eye. The facial nerve carries both motor and sensory fibers to the muscles of facial expression and sensation of taste, respectively. It also carries parasympathetic fibers to various glands. This nerve has 5 divisions: temporal, zygomatic, buccal, marginal mandibular branch, and the cervical nerves. The temporal branch supplies motor fibers to the frontalis and orbicularis oculi muscle. The zygomatic branch also supplies the orbicularis oculi muscle. The buccal branch supplies the orbicularis oris, buccinator, and zygomaticus muscles. The marginal mandibular branch supplies the depressor labii inferioris, depressor anguli oris, and the mentalis muscle. A branch also carries taste sensation from the anterior 2/3 of the tongue. The cervical branch supplies the platysma muscle in the neck. Although it's quite complicated, the facial nerve also provides parasympathetic innervation to the lacrimal gland and mucus glands in the nasal cavity, maxillary sinus, and palate. The Vestibulocochlear nerve is a purely sensory nerve providing balance and hearing sensation. The nerve starts at the vestibular and cochlear nuclei in the brainstem, ending at the internal acoustic meatus, with various branches penetrating multiple structures in the ear. The bony labyrinth of the inner ear includes the vestibule of the ear, the semicircular canals, and the cochlea. The inner ear is right beside the middle ear, which is composed of 3 bones, the malleus, incus, and stapes. The Glossopharyngeal Nerve has motor, sensory, and parasympathetic functions. It provides motor function to the stylopharyngeus muscle, which elevates the larynx and widens the pharynx during swallowing. The nerve also provides taste sensation to the posterior 1/3 of the tongue. The parasympathetic function is innervation to the parotid nerve during salivation. The glossopharyngeal nerve, interestingly, carries the afferent sensory information for the gag reflex, and the efferent nerve is the vagus nerve. The vagus nerve has multiple functions. The vagus nerve's motor function innervates muscles of the pharynx, soft palate, and larynx. It also provides sensation to the skin of the external acoustic meatus and surfaces of the laryngopharynx, larynx, heart, and abdominal viscera. It provides a special sensory innervation of taste to the epiglottis and the root of the tongue. The parasympathetics innervate the smooth muscle of the trachea, bronchi, GI tract, and regulate heart rhythm. The accessory nerve has multiple motor functions to the sternocleidomastoid, trapezius, larynx, pharyngeal constrictors, and soft palate muscles. The sternocleidomastoids allow for the lateral flexion and rotation of the neck. The trapezius elevates, retracts, rotates, and pulls the scapula inferiorly during abduction of the arm. The hypoglossal nerve carries motor nerves to the extrinsic and intrinsic muscles of the tongue. The extrinsic muscles include the genioglossus, hyoglossus, and styloglossus. The palatoglossus is innervated by the vagus nerve. Intrinsic muscles include the superior longitudinal, inferior longitudinal, transverse, and vertical muscles. Together, they all cause movement of the tongue. Moving on to the cranial nerve exam. Cranial nerve 1, the olfactory nerve, is usually not assessed, but we can ask patients if there has been a change to their sense of smell. A more formal way of testing is by using a scratch card with various scents and asking what they smell. The optic nerve, or cranial nerve 2, is assessed initially by looking to see if the pupils are equal, round, and reactive to light. Assess pupillary light reflexes using direct, consensual, and swinging light tests. Also test for accommodation and visual fields. We use the Snellen chart to test for visual acuity. The pupillary light reflex assesses for direct and consensual response to light. This means when light is shone in one eye, that same pupil will respond by constricting. This is the direct light reflex. At the same time, the other pupil without a light being shone on it will also constrict. This is a consensual response. The swinging light test looks for a relative afferent pupillary defect. You perform a pupillary light reflex test on both eyes, swinging from one eye to the other. It is positive for a relative afferent pupillary defect when one pupil or the affected eye dilates instead of constricts, and causes a concentric response in the other pupil. When you bring the flashlight back to the normal pupil, it will constrict and cause a concentric response. A relative afferent pupillary defect indicates unilateral or asymmetric optic nerve pathology, such as asymmetric glaucoma or retinal disease. Test for accommodation by asking a person to keep their eyes on an object. Bring the object close to their face in the midline and slowly bring the object away from their face, still maintaining midline location. Assess how their eyes converge and diverge as they track the object. Visual fields are tested for by asking the patient to look at you. You would close your eyes on the same side as the patient's closed eye and wiggle a finger in the corners of their peripheral vision. They would need to tell you when they can see the wiggling finger. If they cannot see the finger, you would bring it closer to the midline until they can see it. Alternatively, you can also ask them to state how many fingers you're holding up. Lastly, you would look at the retina using an ophthalmoscope. You're assessing for the optic disc and any hemorrhages, blurring of the optic disc, or arterial venous nicking. The oculomotor, trochlear, and abducens nerves all provide motor input to the extraocular muscles of the eye. To assess these muscles, we should perform the H test. Ask the patient to look straight ahead and keep their eye still while they follow your fingertip with their gaze. Your finger should be 30 centimeters in front of the patient's face. Move your finger in an H formation, assessing both horizontal and vertical gaze. We are looking at the pupils to assess eye movements and any signs of nystagmus. Nystagmus is a condition where eyes move rapidly involuntarily. They can move side to side, which is horizontal nystagmus, up and down, which is vertical nystagmus, or circularly, which is rotary nystagmus. During this test, you can ask the patient if they are experiencing double vision or diplopia. You will want to make note of the direction they notice double vision. You will want to assess for any restrictions in their range of motion and any other additional symptoms. An easy way to remember the innervation of the extraocular muscles is SO4, LR6, REST 3. We can test the trigeminal nerve by running a finger along each of VIII, VIII, and VIII zones, and asking if they can feel the finger and if it's the same sensation on the other side of their face. We can test their masseter muscle innervated by VIII by asking them to clench their jaw while we place our fingers above the muscle. You should be able to feel the muscle contracting below your fingers. The facial nerve is responsible for facial expression. We can test the temporal nerve by asking the patient to raise their eyebrows or crinkle their forehead to determine the motor capabilities of the frontalis muscle. We can then test the zygomatic nerve by testing their orbicularis oculi muscle by asking them to keep their eyes closed against resistance. The buccal branch is tested for by assessing their orbicularis oris by asking the patient to show us their teeth and puffing out their cheeks. Moving on to the next branch, we expect the muscles innervated by the marginal mandibular branch to depress the lower lip during a smile. We can assess the marginal mandibular branch while the patient is smiling to look for asymmetry of their lower lip. The cervical nerve is tested for by assessing the platysma muscle. We ask the patient to depress their lower lip while palpating their platysma muscle to feel for a contraction. A quick screening exam of the vestibulocochlear nerve is performed by asking the patient to keep their eyes closed. You will then rub your fingers beside their ears one by one while asking them to point to which side they can hear the sound from. If this test is unremarkable, you can be sure that cranial nerve 8 is intact. If this test shows an abnormality, you can go on to perform more in-depth testing. To determine if it is conductive versus sensory neural hearing loss, you must perform the Rhine and Weber test. In the Weber test, the stem of a vibrating 512 Hz tuning fork is placed on the center of the head, and the patient is asked in which ear the tone is heard louder. In unilateral conductive hearing loss, the tone is louder in the ear with hearing loss. In unilateral sensory neural hearing loss, the tone is heard louder in the normal ear because the tuning fork stimulates both inner ears and the patient perceives the stimulus with the unaffected ear. In the Rhine test, we compare hearing by bone and air conduction. Bone conduction tests the inner ear, cranial nerve, and the central auditory pathways, bypassing the external and middle ear. The stem of a vibrating tuning fork is held against the mastoid. This is to test bone conduction. Once the sound is no longer perceived, we remove the fork and place the still vibrating tines close to the pinna to test air conduction. Normally, air conduction is better than bone conduction, so we'd expect to hear the vibration louder after removal of the fork from the mastoid. With conductive hearing loss, bone conduction is louder than air conduction. With sensory neural hearing loss, both air and bone conduction are reduced, but air conduction remains louder. We can assess the motor functions of the glossopharyngeal and vagus by asking the patient to swallow. We can also depress the tongue with a tongue depressor and ask the patient to say, ah. We're looking for the uvula to rise midline with phonation and can visualize the palate and posterior pharyngeal wall. If you suspect an impairment, then you can use the tongue depressor to touch the posterior pharyngeal wall to elicit a gag reflex. We don't routinely test the sensory function of taste on the posterior 1/3 of the tongue. We can assess the motor functions of the accessory nerve by asking the patient to shrug their shoulders against resistance. We can test each sternocleidomastoid by asking the patient to turn their head to the side against resistance. A deficit in the muscles innervated by the accessory nerve would cause head dropping and scapular winging, where one or both shoulder blades stick out from the back instead of laying flat. We can assess the motor functions of the hypoglossal nerve by asking the patient to place their tongue against their cheeks. We would test the strength of their extrinsic and intrinsic muscles by applying resistance as we try to push against the tongue while the patient tries to keep their tongue in place. Common cranial nerve abnormalities you may see include Horner syndrome and Bell's palsy. Horner syndrome occurs when the sympathetic innervation to the face is disrupted. The classic triad of symptoms are miosis, or unilateral constricted pupil, unilateral ptosis, or eyelid drooping, and unilateral anhidrosis, or no sweating. Facial nerve palsy, otherwise called Bell's palsy if no cause can be found, presents as asymmetric facial drooping and inability to close one eye. It does not affect the rest of the body. Thank you for watching this video on the cranial nerve exam. Please let us know what other videos may be helpful on your plastic surgery rotations.